Hello, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today we're joined by our Medical Director, Dr. Pruitt.
Hey, Chief.
Welcome, Doc. And we're also joined by upgraded Lieutenant Phuc Mai.
Hey, Chief.
Thanks for joining us, brother. I appreciate you. So, like we were talking about, been upgraded a lot more lately. And this is a case you brought to us while you were working at Rescue 18. And it sounds like you all were dispatched to a 28 Charlie 1 for a possible stroke at a residence. Tell us a little bit about that dispatch. Was there any additional information, kind of the things that you're thinking about when you're en route to that call?
No, not really. I think with the dispatch going to the call, we were thinking about Cincinnati, how to get to the patient, where the patient's at. When we were heading over there, 5-5 was actually ahead of us, so we pulled up around the same time. They went to go grab their gurney. We went upstairs, and I was thinking about trying to get the patient's history while my driver was working on patient assessment, and then by that time, AS got there with their gurney and all the stuff that they needed.
And like a lot of the cases that we go to, the information is only as good as the caller can provide. So the alarm room does their best to try to match the chief complaint. But it sounds like there was a lot of different curveballs on this particular call that didn't match up with a stroke, but a lot of thinking that you had to do to treat this patient. So talk with us a little bit about what you saw when you and AAS arrived to treat the patient.
When we arrived, patient was in his bedroom on the second floor. Unconscious, unresponsive. So right away, my driver was working on vital signs. They were trying to do a Cincinnati, but obviously they weren't able to get one because he was unconscious. So I was trying to collect the story from the granddaughter who was there and get as much history as I can. So we sort of divided and conquer. Right away, he got a blood pressure of 60/40. Wasn't really great, so we elected to mega moved him downstairs and still work on vital signs and everything while I was collecting the history. The daughter was saying, or the granddaughter was saying that he's not supposed to be left alone. And so she went to go pick up her kids from school, so her boyfriend was supposed to watch over him a couple of hours ago, came back and noticed that he was outside. They pulled him in, and when he wasn't waking up, they called 911, and that's when we showed up and saw what we were presented.
Yeah, and obviously hot temps this entire late spring into the summer. It's been super hot. As far as his presentation, knowing that he had been pulled from outside to inside, was there anything indicative of him having some heat injuries?
There was. He had some burn marks on his legs and his left forearm, but initially we weren't really thinking hyperthermic emergency. We were working on ABCs, trying to figure out what's going on. Right away got a sugar, and then I don't remember if it was my driver or AAS, but they said that he was hot to the touch, so we thought maybe sepsis since he was pretty tacky. And while we were moving down that route, we thought this might be a hyperthermic. He was outside, and then everything just started clicking. So we started treating it for a hyperthermic reaction since he didn't really meet the sepsis protocol. He didn't have an obvious source of infection.
Yeah, it didn't paint the picture for sepsis, really wasn't painting the picture for stroke, hypotensive, tachycardic, and hot to the touch, and then some burns that you had kind of documented that you had seen on his skin being outside. So yeah, that's interesting change in your thought process. So Doc, talk with us a little about heat stroke. How do we define that, and how would you expect us to treat those types of patients?
So heat stroke is technically any body temperature over 104 degrees, and it can present, it's essentially on a spectrum. So you can have heat illness, which is just like feeling faint, a little bit nauseous. But at the point you have a temp of 104 and you're starting to have any signs of alteration in the mental status. So it can be anything from confusion to lethargy all the way to seizure, coma, death. At that point, it's defined as heat stroke. And once it's defined as heat stroke, the mortality can be as high, the 30-day mortality, according to one article, could be as high as 58% in that month. So it is a pretty dangerous disease. This was a tough case when you're presented with a completely unresponsive patient and you have about a minute or two to figure out where the problem is and how you're going to treat it. I think you did a great job thinking through your quickly reversible things, right? Is this a glucose problem? Ruled that out pretty quickly. And then using the vital signs to kind of base your treatment, and common things being common, especially when you find a patient in a bedroom. Sepsis, I think, was an excellent early idea. Luckily, the treatments for sepsis and hyperthermia are very similar, with fluid bolus, cooling, treating the fever, trying to get the heart rate down.
Yeah, let's talk about that a little bit. So you guys had mega moved him down at this point in the back of the ambulance and getting ready to initiate transport. Talk with us a little about some of the interventions that you were able to complete during transport and during your treatment.
So, initially we didn't really trust our thermometer. Our thermometer was reading 108 for the tympanic. So we used 5.5 and they were still 106. So we just wanted to re-verify the vital signs right away. When we saw the vital signs, or when we saw the temperature was so high, we started actively cooling him. We got a few ice packs, put it around the carotid, put on his chest, put on his head, his groin area, and both armpits. My driver actually got some trauma dressing, soaked it with IV fluids, and started covering his legs and his extremities. And he worked on a line right out the bat while I was trying to chart everything out and get a 12 lead. So we were working on the 12 lead as well.
That's awesome. So started the rapid cooling, got the IV going. Roughly, do you know how much fluids you ended up giving him, and there was a response to that?
By the time we got to the hospital, we got about 1,500 cc's of fluids in.
Did you start to see a change in mentation or activity after your treatments?
Yeah, so when we were checking his pupils, it was glossed over. It was equal and reactive, but it was a little sluggish and glossy over. So by the time we got to the hospital with all the fluids in, he was starting to react a little bit more with that. And by the time we were turning over to the hospital, he was starting to move around again, and his vital signs starting to look more normal than how he was previously presenting.
Yeah, it looks like we had heart rate was still high, obviously, but looked like the blood pressure improved about a 112 for a systolic. Looks like you got your O2 sats up to 95. His temperature was about a 103, and you'd already addressed the sugar, so that was a non-issue. Talk with us a little bit, Doc, about his this patient's turnover at the ED. What was the next steps based on? They basically provided all the treatment to save the individual's life. What did they do to carry on that care?
Yeah, so he was still basically non-responsive at that point, but his vital signs had improved. And whenever I think about a patient who is unresponsive and I'm trying to think quickly through an altered mental status presentation, I think of like basically 5 big categories of altered mental status. First one being vital signs, which it sounds like these guys had ruled out vitals being maybe he's hypotensive, but you fixed that. Attempted to correct and get the temperature on the right trajectory, and then ruled out the glucose. So vital signs didn't seem to be the cause here necessarily. Tox metabolic, this could very much be a metabolic problem with maybe a thyroid storm or something like that, most likely environmental. But that's always the second thing, I think, is this a toxicology issue? Is it ischemic? You guys did a great job getting a 12 lead, because obviously cardiac arrhythmias in an elderly person can also cause altered mental status. Any kind of structural abnormalities, so he was found down, maybe he's got bleeding in his brain that we need to evaluate for. And then lastly would be psychology as a cause. Because he was so altered and they needed to move quickly to find the root of the problem, they did intubate him in the ED, got a CAT scan of his head, didn't find any bleeding, and so at this point it's looking more and more like it's hyperthermia and heat stroke. So they continued the active cooling that you had initiated. He did get admitted to the ICU. Interestingly, I think he was probably down for quite a while. what they found was he had acute renal failure and was actually in rhabdomyolysis. When your muscle breaks down from laying on the ground for too long, those big molecules in the muscle are released and they cause kidney damage. And so we measure that in the blood. It's called a CK. His CK levels were over 6,000, which normal is around 50 or 60. So they're very, very high. He ended up needing dialysis, getting a lot of fluid. The fluid that you started, your 1,500 cc bolus, was exactly on the right trajectory. And you did all this without lab work, so that's great. And he's starting to wake up a little bit in the ICU now that his renal failure has corrected. And it's still unclear exactly how he ended up unconscious on the floor. But they did also find the marks you noticed on his skin. He did have a 15% body surface area burns just from the contact with the ground, which is unbelievable how hot it can be out there. So they're continuing to treat his burns as well. Some of them were so severe they needed skin grafting. So he's getting a lot of wound care currently.
Wow. Incredible work. I think we talk about it a lot with a lot of our newly upgraded LTs, which kind of you're in that role right now. So looking back at this call, trying to basically from where you started with assessing, is this a stroke? Is this sepsis? Is this a glucose issue? No's to all those, and then kind of zeroed in on the hyperthermia piece and the burns. I couldn't think of anything you could have ever done differently, but now that you've been a part of this call, is there any recommendations, suggestions that you would give to new providers or other providers out in the field when they encounter calls like this?
I think just focus on getting the patient out of the environment, rapid transport, active cooling. Those are probably the main highlights. Fortunately, we got bilateral lines, 18 and a 16 gauge, so we were able to drop fluids pretty quickly. And I think what helped us out, considering we were at 18s, we were so far away, we figured we could do a lot of the treatment en route and get the patient to definitive care.
Awesome. Well, fantastic work, Fook. You did an amazing job on this, and I think I've had the opportunity to work with you. I think since you first came into the department, you were under Captain Rob Laprice for a long time as you were starting out, and just showed the initiative, and now it's paying off today with the education that you're providing to everybody else and the great care that you're giving out there. So thank you for taking the time to come and talk about the call with us.
Anytime, Chief. Thanks.
Awesome. All right, that's it for today. If anybody has any interesting cases they want to bring, use the SharePoint tab or reach out to anybody in the EMS cadre, and we'll get you down here to come and record. Until then, we'll see you next time. Thanks.